ABVD chemotherapy is a combination of 4 different cytostatic agents that have been used for more than 40 years for the treatment of Hodgkin lymphoma. And it's the standard of care for treatment of advanced stage disease in many regions and centers in the world. It cures roughly 2/3 of the patients, a little bit more, but that leaves roughly 30%, perhaps 25 to 30% of patients still prone to either being refractory to first-line therapy or relapsing at a later point in time. So there is an unmet medical need when you use ABVD for the treatment of Hodgkin lymphoma. There are other shortcomings in terms of toxicity as well. It's not a completely untoxic regimen, even though it is relatively well tolerated. The ECHELON-1 study was a large randomized international study with more than 1,300 patients, directly comparing ABVD, the standard of care chemotherapy, with the experimental arm, which was ABVD without bleomycin and with the addition of Brentuximab vedotin, which is a novel agent in the treatment of Hodgkin lymphoma. So essentially it's a head-to-head comparison of bleomycin and Brentuximab vedotin compared with 3 drugs that are used in both arms, called AVD. Bleomycin is a drug that we have wanted to get rid of for a long time because it's quite toxic for the lungs, so a proportion of patients who receive this drug, particularly receive it over a long time, like patients with advanced stage Hodgkin lymphoma do, will develop a lung toxicity, and for some patients that can indeed be fatal or chronic. So it's been a desire for a long time to get rid of that drug and at the same time to improve the overall efficacy of the regimen. So that's the background for this study. The ECHELON-1 study showed superior efficacy for both patients with stage 3 and stage 4 disease, both of whom were included in this protocol. And there was an overall benefit of 4.9% in 2-year modified progression-free survival in favor of the experimental arm compared with the standard arm, particularly in the high-risk groups, and that was prior to the study defined as patients with stage 4 disease or patients with extranodal disease, so disease in the organs outside of the lymph nodes. This benefit was more clear, and there was even a benefit for the important clinical endpoint of overall survival, which is really what it's all about. And conversely, for patients with low risk, here defined as stage 3 or no extranodal disease, there was no statistically significant benefit. Now, you asked me about toxicity. When taking out bleomycin, you get rid of almost all of the feared lung toxicity, so that is the good news. But for the experimental arm, adding Brentuximab vedotin, one of the well-known side effects of that drug is neurotoxicity, giving the patients what we call peripheral neuropathy, which was apparent in a larger number of patients in the experimental arm than in the standard arm. Also, the new drug is myelotoxic, which means that it depresses the bone marrow function, like many other cytostatic agents. That is not the case for bleomycin, which meant that in the experimental arm there were more cases of deep thrombocytopenia and neutropenia, and the latter leads to a higher rate of infections. Some of these infections quite serious. So in the beginning of the study, there were indeed serious infections and fatal infections in the experimental arm, which was not so commonly seen in the standard ABVD arm. That led to an amendment of the protocol, so all patients in the experimental arm, after a certain period of time, were all given what we call GCSF prophylaxis, so compulsory prophylaxis with an injection that stimulates the generation of white blood cells in the bone marrow. And after that amendment, where all patients had GCSF prophylaxis, that large initially seen difference in the rate of serious infections disappeared. The vast majority of patients respond to treatment in the first place. This is first-line treatment. It's Hodgkin lymphoma, despite the unmet medical need that I mentioned, is one of the most chemosensitive diseases or cancers that we know. So the vast majority of patients will respond, high up in the 80s, even 90, around 85–90% of patients. And that is more or less regardless of whether you use ABVD or Brentuximab vedotin. But response is not the interesting endpoint in a setting like this. We're talking about a curable disease hitting primarily young people with a lot of years to live after having been treated and hopefully cured. So what really matters are the more clinically relevant endpoints of progression-free and particularly overall survival. And those patients who are more likely, in terms of those endpoints, to benefit from the experimental treatment as compared with the standard treatment are the ones with high risk. So stage 4 disease, extranodal disease, high number of risk factors as determined by the International Prognostic Hodgkin lymphoma risk factor score. So these are the patients that you are more likely to, who are more likely to benefit from the experimental versus the standard treatment. There's no worldwide standard of care for advanced stage Hodgkin lymphoma. So ABVD is one standard. Another standard is a more intensive, more toxic regimen called BIACOP escalated. And for a long time, you would either, according to geography, preference, policies, treat patients with ABVD or BIACOP escalated. ABVD mainly used in North America, the UK, many European countries and worldwide, and BIACOP escalated more concentrated around Germany and its neighboring countries in Central Europe. That has completely changed. We've introduced particularly PET scans early during treatment, which are used to stratify patients into different risk groups and indeed amend treatment according to the results of that PET scan. So nowadays we start with either ABVD or BIACOP escalated, and we escalate or de-escalate treatment according to the initial response. Now we have the experimental arm of ECHELON-1, it's A+AVD or Brentuximab vedotin AVD. That is another tool in a growing toolbox of treatments for advanced stage Hodgkin lymphoma. There is also a study led by the German Hodgkin study group comparing BIACOP escalated that I mentioned with a novel and hopefully improved version of that regimen containing, like the experimental arm of ECHELON-1, also Brentuximab vedotin, along with a number of other cytostatic agents. So that randomized comparison will also perhaps give us another tool, just like we got one from the ECHELON-1 study. So we have the choice between more intensive and less intensive, BIACOP-like or ABVD-like. We have the choice between something containing targeted agents like Brentuximab vedotin or conventional chemotherapy alone, and we also have the possibility to adapt treatment according to initial response. So that is what we are going to further develop in the future. We're a long way down the road, and now we're introducing novel agents like Brentuximab vedotin into this clinical strategy.